Alright, so with the mind maps on the principles of toxicology, let's continue with toxicodynamics. Um, and then we'll look at some spectrum of undesired effects. So the spectrum of undesired effects of chemicals is so broad, and well, try and analyze our mind maps very well, and will help you remember some of these things. That some effects are deleterious and others are not. And in therapeutics, each drug produces many effects, but usually only one effect is associated with the primary objective of the therapy, and all the other effects are referred to as undesirable or side effects of that drug for that particular therapeutic indication. However, some of these side effects may be desired for another therapeutic indication. For example, diphenhydramine, Benadryl, and Benadryl is an effective antihistamine for allergies, but it's readily enters the brain and causes mild CNS depression, for example, drowsiness, delayed reaction time. It's therefore widely used as an over the counter sleep remedy, often in combination with analgesics, taking advantage of the CNS depressant effect. But some side effects of the drug are never desirable and are always deleterious to the well-being of humans, and these are referred to as the adverse effects or toxic effects or deleterious effects of the drug. I hope you get this point very well from the mind map. Okay, so the types of toxic reactions include pharmacological reactions, pathological reactions, and also genotoxic reactions. And with the pharmacological reactions, toxic reactions, an example could be excessive depression of the central nervous system by barbiturates, and with a pathological, for example, in hepatic injury produced by acetaminophen. For genotoxic, that's alteration in the DNA, for example, a neoplasm produced by a nitrogen mustard. And the incidence and seriousness of these reactions are related to the concentration of the toxic chemical in the body. And if the concentration of the chemical in the tissues does not exceed a critical level, the effects usually will be reversible. The pharmacological effects usually disappear when the concentration of drug or chemical in the tissues is decreased by biotransformation or excretion from the body. Okay. It's the pathological and genotoxic effects may be repaired if these effects are severe. That may ensue within a short time, and more subtle damage to DNA that is not repaired may cause cancer few months or years in the lab animals, or even in a decade or more in humans. So more on the pharmacodynamics, allergic reactions, and also um, hypersensitivity reactions are very important when it comes to toxicodynamics. So chemical allergy is an adverse reaction that results from previous sensitization to a particular chemical or to one that is structurally similar. So such reactions are mediated by the immune system. So allergic reactions are just a subset of hypersensitivity reactions, and for a low molecular weight chemical to cause an allergic reaction, it or its metabolites usually act as a hapten, combining with endogenous protein to form an antigen complex. And such antigen complex, what happens is that the antigens induce a synthesis of antibodies, usually after a latest period of at least 1 to 2 weeks, and subsequent exposure to the organism to the chemical usually results in an antigen antibody reaction that provokes the typical manifestation of allergy. The dose response relationships usually are not apparent for the provocation of allergic reactions. With allergic hypersensitivity reactions, the hypersensitivity responses are divided into 4 general categories based on the mechanism of immunological involvement. So type 1 is allergic, anaphylactic, or immediate hypersensitivity reactions, and it's mediated by IgE, so immunoglobulin E, and the main targets the GIT, for example, food allergies, the skin, urticaria, and atopic dermatitis, respiratory system, in rhinitis, asthma, and also in the vasculature, that's cause anaphylactic shock. So first exposure, antigen presenting cell presented to the T cell, T helper cell, B cells, differentiates into plasma cells. Immunoglobulin E is reproduced, and then it binds to the antigens. So once there is the mast cells basophils, and once there is array exposure, they degranulate and release histamine, leukotrienes, and other mediators, and cause all these allergic reactions. Alright, so type 2 is basically cytolytic reactions, and it's mediated by IgG and IgM, so immunoglobulin G and immunoglobulin M, which involves activation of the complement system. So the major targets, the cells in the circulatory system is the major target. For example, penicillin-induced hemolytic anemia, methyl dopamine-induced autoimmune hemolytic anemia, quinidine-induced thrombocytopenia, or thrombocytopenic purpura, and also sulfonamide-induced granulocytopenia too. So this usually subsides within several months after removing the offended agent. And with type 3, or the adverse reaction, is usually mediated by IgG, immunoglobulin G, which involves the generation of antigen antibody complexes that subsequently fix complement. The complexes are deposited in the vasculature or the vascular endothelium, leading to destruction of destructive inflammatory response called serum sickness, and this contrasts with the type 2 reaction, in which the inflammatory response is induced by antibodies directed against tissue antigens. And the signs and symptoms of serum sickness, for example, urticarial skin eruptions, arthralgia, and arthritis, to lymphadenopathy and fever could all occur. The reactions usually last for 6 to 12 days and then subside after the offended agent is eliminated. So several drugs, for example the sulfonamides, penicillin, certain anticonvulsants, iridides, can induce serum sickness. So what happens is that the immune complexes form, and then after forming, the complexes deposit on the vessel walls or the tissues, and the complement and neutrophil activation happens as inflammation is being triggered. You have your complement system C3b, C5a, and then back from antigen antibody That's complex being formed from IgG and antigen neutrophils, complex deposition in the vessel walls, complement system, neutrophil activation and inflammation, and then finally, there's increased permeability and tissue damage. Then cytokines are being released, enzymes, reactive oxygen species to also being released. Okay, so that's for type 3. For type 4, it's basically delayed type hypersensitivity. So it's mediated by sensitized T lymphocytes and macrophages, and when sensitized cells come in contact with antigen, an inflammatory reaction is generated by the production of lymphokines and subsequent influx of neutrophils and macrophages. For example, contact dermatitis caused by poison ivy, nickel latex cosmetics, and also Steven-Johnson syndrome and toxic epidermal necrolysis from sulfonamide and penicillin. So one thing that you could distinguish Steven-Johnson syndromes from toxic epidermal necrolysis is that Steven-Johnson syndromes, there's a small surface area that has been affected by toxic epidermal necrolysis. That one is a very large surface area, and they are all from the sulfonamides and also the penicillins. And drug reaction from with eosinophilia and systemic symptoms, for example, from carbamazepine, lamotrigine, or phenytoin could result in type 4, the delayed hypersensitivity reactions. So that's the drug reaction with eosinophilia and systemic symptoms. Alright, so antigen presenting cells comes to T lymphocytes, sensitization of this, the cytokines are being released, macrophages becomes activated macrophages, there is granuloma formation of activated macrophages, and that will lead to several other reactions too. Alright, so that's for the type 4, but one that you should always remember is the idiosyncratic reactions. So with this is an abnormal reaction to a chemical that is particular to a given individual, a specific individual, and it may take the form of extreme sensitivity to low doses or extreme insensitivity to high doses of chemicals, and can result from genetic polymorphisms that cause individual differences in drug pharmacokinetics. So increased incidence of peripheral neuropathy seen in patients with inherited deficiencies in acetylation when isoniazid is used to treat TB. That's an example. So 10% of blacks or males develop a serious hemolytic anemia when they receive primaquine as an anti-malarial therapy, and such individuals usually have a deficiency in erythrocytes, GSSPD, and genetically determined resistance to warfarin due to an alteration in the vitamin K alkoxide reductase, or inherent sensitivity to warfarin is due to polymorphisms in CYP2, C9, cytochrome that's what the examples of some idiosyncratic reactions too. So with response, the degree and the spectra of responses to toxicants depend on the dose and the organism. So there's a change from the normal state, and it could be on the molecular level, the cellular organism level, and the symptoms, whether local or systemic, reversible or irreversible, immediate versus delayed, and graded versus quantile, degrees of the same damage versus all or none. Yes, so certain things do okay. So the local and versus systemic to- toxicity, one thing that you realize is that the local toxicity occurs at the site of first contact, and the systemic toxicity requires absorption and distribution of the toxicant. So most substances, except highly reactive chemical species, produce systemic toxic effects, and the two categories are not mutually exclusive. So tetra ethyl lead injures skin at the site of the contact and deleteriously affects the central nervous system. But most systemic toxicants affect one or few organs, and the target organ of toxicity is not necessarily the site of accumulation of the chemicals. For example, lead is concentrated in bone, but its primary action, toxic action, is on soft tissues. And DDT, as chlorophenol, is concentrated in adipose tissues, but produces no known toxic effects in the adipose tissues. So systems most affected in order of frequency includes the central nervous system and then the heart circulatory system, followed by the blood and hematopoietic system, the visceral organs such as the liver, kidneys, and lungs, skin, muscle, and bone, at least, are also often affected. And with substances that have predominantly low local effects, the frequency of tissue reaction depends largely on the port of entry. For example, whether the skin, GIT, or the respiratory tract. So for reversible versus irreversible toxic effects, the effects of the drugs on the humans, whether possible, must be reversible. Otherwise, the drugs would be prohibitively toxic. And if a drug produces an injury to a tissue, the capacity of the tissue to regenerate or recover largely would determine the reversibility of the effect. For example, as seen in myocardial infarction. So injuries to a tissue such as the liver, which has high capacity to regenerate, usually are reversible. But injury to the central nervous system, which is largely irreversible because of the highly differentiated neurons of the brain, have more limited capacity to divide and regenerate. So with delayed toxicity, most toxic effects of drugs occur at a predictable, usually short time after administration. However, this is not always the case. Aplastic anemia caused by chloramphenicol may appear weeks after the drug has been discontinued, and carcinogenic effects of chemicals usually have a long latent period, like 20 to 30 years, and may pass before tumors are observed. So daughters of mothers who took diethyl stilbestrol during pregnancy at higher risk of developing vaginal cancer in young adults who typically 20 to 30 years after exposure, but will not other types of cancer. So that is, you might not know where it originated from. Then taking this diethyl stilbestrol DES could result in that several decades after. So delayed nephrotoxicity after exposure to some organophosphate insecticides that act by covalent modification of neuropathy target esterase. There's a neuronal protein with serine esterase activity. So binding of certain organophosphates such as TOCP, trialtocresol triacylcrystal phosphates. Yeah, triacylcrystal phosphates, the most notorious two NTEs, the neuropathic target esterase, initiates the degranulation or degeneration of long axons in the peripheral nervous system and the central nervous system. And due to the difficulty in assessing delayed effects during initial chemical evaluations, there is an urgent need for reliable short-term toxicity tests and systemic long-term surveillance of marketed drugs and chemicals. Alright, so one thing that we have to remember is that chemical carcinogens are classified on genotoxic or non-genotoxic means or basis. The genotoxic carcinogens interact with DNA, non-genotoxic carcinogens do not interact with DNA. The chemical genotoxic carcinogenesis is a multi-step process, and most genotoxic carcinogens are themselves on-reactive. So these chemical carcinogens, procarcinogens or promate carcinogens, they are converted to primary or ultimate carcinogens in the body, and drug metabolizing enzymes often convert the proximate carcinogens to reactive electrophilic intermediates. So these reactive intermediates can act with nucleophilic centers in DNA to produce a mutation. As the initial step in chemical carcinogenesis, the DNA may revert to normal if DNA repair mechanisms operate successfully. If not, the transformed cells may grow into a tumor. So with non-genotoxic carcinogens or promoters, they do not produce tumor alone, but they do potentiate the effects of genotoxic carcinogens, and the time from initiation to the development of the tumor probably depends on the presence of such promoters. For many humans, tumors, later period is 15 to 45 years. So that's something we know about chemical carcinogens also. That you have to realize is that when it comes to screening for potential carcinogenicity, we have the mutagenicity test, that's the AMC test, and also the chronic carcinogenicity testing. So with the mutagenicity testing, which involves the AMC test, so many carcinogens are mutagens, and with the AMC test, a reverse mutation assay using salmonella and typhimurium. So a mutant gene is being used over here. The strain of salmonella has this mutant gene for phosphoribosal ATP synthesis, which is necessary for histidine synthesis. So the growth conditions, the bacteria cannot grow in a histidine deficient medium unless a reverse mutation occurs. And with the chemical activation, many chemicals require activation by enzymes in the endoplasmic reticulum to become mutagenic or carcinogenic. and right hepatic microsomes too. These are added to the medium to facilitate the activation of the chemicals. So mutagenicity of a substance is proportional to the number of colonies observed. The test is rapid and sensitive. It is only useful, or it's very important or useful for the prediction of genotoxic carcinogens. But when it comes to chronic carcinogenicity testing, the test consists of feeding lab rodents at high doses, like with the chemicals at high doses of for their entire lifespan, which after autopsies and histopathological examinations are performed on each animal, and they can detect both homotest and genotoxic carcinogens. So with this, the high doses being given to a particular set of rodents. So with a high dose of this toxicant, and you have another set which you just give a placebo, and then with the results you get to know what to do from there. Alright, so we'll go ahead with with the interaction type, or the interaction between the chemicals, one thing that you have to realize is that the concurrent exposures may alter the pharmacokinetics or pharmacodynamics of the drugs. For example, when you take atropine, it's used to treat organophosphate poisoning or insecticide toxicity, and it's actually muscarinic receptor antagonist, and then it blocks prevents acetylcholine from binding to the receptors, and then inducing more at the synaptic cleft. Organophosphate poisons to inhibit the acetylcholine esterase, and thereby having so much of the acetylcholine in the synaptic cleft, inducing more contractions across the postsynaptic membrane. So aspirin and heparin given together can cause unexpected bleeding, and the response to combined toxicants may be equal to, or even greater, or even less than the sum of the effects of the individual agent. So these interactions, the interaction type, we have the additive effect, potentiation effect, synergistic effect, and antagonism. So with the additive effect, it describes the combined effect of two chemicals that equal the sum of the effects of each agent given alone. So the additive effect is the most common. For example, just maybe it has 2 and then 3 causes 5. Then you have a higher dose, but just some of the individual effects. Or potentiation, the increased effect of a toxic agent acting simultaneously with a non-toxic one. So let's take isopropanol. So isopropanol alone, for example, is not hepatotoxic, but when it's taken with carbon tetrachloride, when it's kind of hepatotoxic. So basically you have, let's say, carbon tetrachloride, then isopropanol, which is non-hepatotoxic. It just increases the hepatotoxicity of carbon tetrachloride, and that's what we call potentiation. But synergistic effect is just one in which the combined effects of the two chemicals exceed the sum of the effects of each agent given alone. So carbon tetrachloride and ethanol are hepatotoxins, but together they produce much more injury to the liver than expected from the sum of the individual effects. Yeah, it's like almost 2 plus 2 is equal to 20. But potentiation is just like 2 for carbon tetrachloride and 0 for isopropane, producing like 50. But the last one has to do with the antagonism, is the interference of the chemical with the action of another, and the antagonistic agent is often desirable as an antidote. So those are the major interference or interaction types that we have. So functional or physiological antagonism occurs when two chemicals produce opposite effects on the same physiological function. For example, the use of IV infusion of dopamine to maintain perfusion of vital organs during certain severe intoxications characterized by marked hypotension. And yes, so that's for functional physiological antagonism. But for chemical antagonism or inactivation, is a reaction between two chemicals to neutralize their effect. For example, dimecapryl chelates various metals to decrease their toxicity. Okay, that's one. For dispositional antagonism, is the alteration of the disposition of a substance, its absorption, biotransformation, distribution, or excretion, so that less of the agent reaches the target organ or its persistence there is reduced. So prevention of absorption of a toxicant by let's say ipecac or charcoal, and increase the excretion of the chemical by administration of an osmotic diuretic or alteration of the pH of the urine. That's one example of dispositional antagonism. Another one is if the parent CPD is responsible for the toxicity of the chemical, for example warfarin, and its metabolic breakdown products are less toxic than the parent CPD, increasing the compound's metabolism of by administering a drug that increases the activity of the metabolizing enzymes. For example, phenobarbital will decrease its toxicity, and if the chemical's toxicity is largely due to a metabolic product, for example organophosphate, insecticide, parathion, inhibiting its biotransformation by an inhibitor of microsomal enzyme activity would decrease its toxicity. Microsomal enzyme activity like SKF 5 to 52-5A, so 525A, or pyronal butoxide. Yeah, this would decrease its toxicity. Receptor antagonism entails the blockade of the effects of an antagonist, of an agonist with an appropriate antagonist that competes for the same site. So that's the receptor antagonism. It entails the blockade of the effect of an agonist with an appropriate antagonist that competes for the same site. For example, the antagonist naloxone is used to treat respiratory depression produced by opioids, and anti-estrogen drug tamoxifen to lower breast cancer risks among women at high risks for this estrogen-related cancer. So tamoxifen competitively block estradiol from binding to its receptor. The treatment of organophosphate insecticide poisoning with atropine, for example, is an example. It's an example not of the antidote competing with the poison, but the receptor, that is the cholinesterase, but it involves blocking the receptor, a cholinergic receptor, for the excess acetylcholine that accumulates by poisoning of the acetylcholinesterase by the organophosphates. Okay, so let's end with tolerance. With tolerance, is a state of decreased responsiveness to a toxic effect of a chemical resulting from prior exposure to that chemical or to a structurally related chemical. So two major mechanisms, that is, there's a decrease in the amount of toxicants reaching the site where the toxic effect is produced, and a reduced responsiveness of tissue to the chemical. So two chemicals known to produce dispositional tolerance are carbon tetrachloride and also cadmium. Yes. So carbon tetrachloride actually produces tolerance to itself by decreasing the formation of reactive metabolites, which is the trichloromethyl radical, and that produces liver injury. So cadmium tolerance is due to induction of metallothionein, metal binding protein, subsequent binding of cadmium to metallothionein rather than to critical macromolecules decreases its toxicity.